Our speaker today is Dr. Heather Evans. Heather, I'll pass it to you now.
Thanks, Katie. This is Heather speaking. So hello and welcome everyone to the first of 4 webinars in a series presented by the Oregon Health Authority and the Northwest ADA Center. Today, we're going to lay some foundations for thinking about and working with people with disabilities, specifically designed for healthcare practitioners. So on our agenda for today is to learn about this webinar series a little bit. I will introduce myself as today's presenter, and then we're going to explore disability from a diversity perspective. We'll learn about the persistence of disability bias in healthcare, and then at the end of it, we'll have about 15 minutes or so for some Q&A. So as was just mentioned, this is part 1 of a 4-part series of webinars on the ADA, or Americans with Disability Act, and healthcare. In addition to 4 webinars, we've also curated fact sheets and a series of short videos on topics relevant to healthcare practitioners who work with patients and colleagues with disabilities. This is a collaboration between the Oregon Health Authority and the Northwest ADA Center. The Northwest ADA Center provides information and training on the Americans with Disabilities Act to residents of Oregon, Alaska, Idaho, and Washington. You can reach out to us anytime to get answers to questions about the ADA. And for more information on this collaborative series, we've given you the website on this slide where you can find those tools. So I want to take just a moment and introduce myself. So my name is Heather Evans. I am a white cisgendered woman. For those with low or no vision, I have brown and gray chin-length hair. I'm wearing a black flowered top. I identify as disabled. I have a chronic illness that causes a variety of physical and cognitive impairments that flare and fluctuate depending on different circumstances, as well as a mental disorder. And in addition to the lived experience that I bring to this work, I have a PhD in sociology. I work at the University of Washington here in Seattle as an assistant professor in the Department of Rehabilitation Medicine. I am also currently the director of the UW Disability Studies academic program. And in addition, I have the pleasure of serving as the Director of Research for the Northwest ADA Center, and I'm one of 2 associate directors for the ADA National Network Knowledge Translation Center, which is a lot to say. So I share all of this information to signal with you that this work is really important to me, both personally and professionally, and I am delighted to be here with you today. All right. So with that housekeeping out of the way, let's focus on today's objectives. Really what we want to accomplish today is begin to understand disability from a diversity perspective. We want to reflect on how US history impacts our current perceptions of disability, examine how multiple, sometimes conflicting definitions of disability became embedded in federal legislation. We want to understand the historical and political context in which different language conventions around disability emerged. And we want to recognize the impact of persistent disability bias and the ways in which accessibility barriers really perpetuate systemic marginalization. So let's talk about disability from a diversity perspective. What does that mean? Well, I want to start by introducing you to the field of disability studies. This is an area of scholarship that shapes how many of us at the Northwest ADA Center approach disability. And one way to think about disability studies is to think of it as kind of the academic arm of the disability rights movement. Disability studies is an interdisciplinary field of scholarship that explores disability as a social, cultural, political, and legal construct. So this is a field that interrogates the really socially constructed nature of that category of disability, tracing the ways in which disability has been defined differently in our history and placing those definitions kind of in the political context in which they emerged. And that means that we examine intersectionality, or the ways in which assumptions about and perceptions of disability shape is shaped and shaped by our other identities, such as race, gender, sexuality, socioeconomic status, age, just to name a few. And one of the key things to understand about disability studies is that we take as our starting point of inquiry not the limitations of individual bodies or minds, but instead we shift our focus to the ways that we have intentionally designed built and social environments to really cater to the needs and preferences of one way of being or thinking, and how that erects barriers for those who don't fit into that archetype. So on this slide is an illustration of a wheelchair using stick figure at the bottom of a staircase parked next to a sign that unironically says, "Entrance, all are welcome." And for those with vision, you will see that our stick figure is not sad, but angry at such an impasse. And so the reason that we want to introduce the field of disability studies is to acknowledge that there's lots of models of disability out there, but we can abstractly categorize different models and definitions into two broad frameworks. And in the United States, I guarantee you that we have all been socialized into a deficit framework or perspective of disability. Key aspects of thinking about disability from a deficit perspective is that any kind of variation from what is seen as typical is seen as bad. Now, note when we start to use terms like good and bad, we're assigning value. And so, with this logic, then, society should seek to minimize that bad variation within its members. In a deficit framework, then, disability is seen as a trait or a fixed attribute of an individual and isn't contextual, doesn't change with the circumstances. And if you're embedded in the research on disability, you'll come across the dominant deficit-based model today, which is referred to as the medical or individual model. And this, in my opinion, is a very unfortunate name because it makes it seem at first blush like there's something wrong with medicine, which is not the argument here. Really, this model should be called the pathology model because it essentially pathologizes difference. This way of thinking about disability asserts that modern medicine and technology will cure all of us of any kind of bodily or cognitive difference, and thus eventually erase disability altogether. So following this logic, the solution is to fix, treat, rehabilitate, or cure the impairment. And if we use this as our starting point, then we can understand why this model leads to the assertion that measures to prevent disability should always be taken. Now, I want to pause here for a moment, and I want you to reflect on that argument. For example, you might think about the ever expanding number of tests available to pregnant parents to give them options of what types of children should or should not be born. But before we get too far down that road, I want you to juxtapose this with thinking about a framework for understanding disability as part of the diversity of human experience. Arguing that differences in the way one communicates, moves, thinks, senses visual or auditory input is, well, just different. And in most cases, not better, not worse than the way anyone else communicates, moves, thinks, senses visual, auditory input. So, from a diversity perspective, variation is really seen as just natural. And in fact, diversity is seen as valuable. The argument in that line of logic, then, is that society should seek to enable all of its members to participate to their maximum capacity. And this understanding then suggests that disability is not a fixed trait of an individual, but instead it's a socially constructed status, meaning that it's kind of changed over time and across space. And again, for those who are really mired in the research, you'll encounter probably the most dominant model under the diversity framework is called the social model of disability. And this model simply normalizes difference, arguing that everyone has or will eventually experience impairment. Therefore, the solution is to remove barriers of exclusion, and that process may or may not include medical or technological augmentation. So from this perspective, measures to prevent disability might be taken, but not always. This perspective rejects the assertion that there are really easy, clean lines to be drawn around who has the right to be born, who has the right to access life-saving treatment, and who has the right to make those decisions. So hopefully juxtaposing these two paradigms helps us really understand why folks who study disability from a diversity perspective have a more nuanced definition of this social status. A diversity perspective defines disability as an interaction between one's way of functioning and the social and built environment in which they find themselves. So individuals may have a non-typical or even impaired functioning, but that it's societal barriers that disable individuals. As an aside, this is the definition of disability that very closely aligns with that of the World Health Organization. Now, we often make a distinction between disability and impairment being a non-typical way or degree of functioning, which can include physical, mental, emotional, or psychosocial modes of functioning. And that leads us to understanding ableism as the set of assumptions and practices that promote differential or unequal treatment of people because of actual or even presumed body or mind difference. Now, if this definition feels familiar to you, that is probably because this is the definition that shows up in our disability civil rights laws. And there is a reason why the ADA, for example, talks specifically about impairments, talks about stigma, and it's because it is a diversity perspective definition and a hard one definition, but I'm getting ahead of myself. So now that I have spent 10 minutes giving you the academic explanation of this, I want to show you a short 2-minute video that I think does a far better job of demonstrating how this shift in thinking about disability can impact a society.
Imagine a town full of physically impaired people, all wheelchair users. They run everything. There aren't any able-bodied people, so naturally, when they built the town, the community decided it was pointless to have ceilings 10 foot high and doors 7 foot high. So the ceilings were built at 7 foot and the doors at 5 foot. In every way, they designed the place the way they wanted it. One day, a few able-bodied people come to stay. One of the first things they notice is the height of the doors. And the reason they notice is because they keep hitting their heads. They come to stand out by the bruises they carry on their foreheads. Soon doctors, psychiatrists and social workers all become involved. Committees are formed. Many people are worried about what becomes known as the problem of the able-bodied. Throughout the town there is a growth of real concern. Specially toughened helmets are handed out, free to the able-bodied to be worn at all times. Braces are designed which give support and relief, while keeping the able-bodied wearer bent to normal height. Various groups of compassionate wheelchair users get together and form registered charities. Every quarter they have a collection day. Upturned helmets are left in pubs and shops for people to drop their small change into. There is talk of founding special homes. But then one day, it dawns on the able-bodied that there is nothing actually wrong with them, just that society excludes them. Imagine a town full of physical...
I'm sure I could work my technology eventually. So I'm hoping that, this short video, again, it provides a little clarification and serves as some food for thought about how different things can seem when you simply switch your perspective. So now that we've defined disability, impairment, and ableism, we want to acknowledge that ableism is really pervasive and persistent today. And so as a breakdown, to get a little more detailed, ableism is a form of discrimination that includes an assumption that able-bodiedness is the norm or the ideal. It leads to differential and inequitable treatment based on actual or presumed non-typical functioning, that is discrimination. It's pervasive across the built environment, social attitudes, policies, and practices, and it's intersectional. That is, it's rooted in the other isms, such as racism or sexism. It's critically important to understand that ableism seeps into every facet of our society, our language, our built environments, our policies, our traditions, our way of viewing the world and the people around us. But why is the question? Why is ableism so entrenched in our society? Well, in part, it's because we haven't and we still don't have one unifying definition of disability. And that's in part because we have a variety of stakeholders who are invested in defining disability for different purposes and who emerged at different times. So just to give you one quick example, we might think of the way disability is defined under the Social Security Act. Under this act, you're considered disabled if you cannot do work that you did before, and a specialist decides you cannot adjust to other work because of your medical condition, and your disability is expected to last for at least a year or result in death. So that's a cheery definition, right? But really, to understand why ableism has hung on for so long, despite civil rights legislation passed 30 years ago, we need to understand the role that disability as a category has played in our history. And that's what we hope to give you today, a foundations. So right now, I'm going to take us through a short skim through some very early US history. There are many stories to tell about disability as a concept during the last century and a half. And I want to share with you just 3 examples of how disability bias or ableism shaped the lives of disabled Americans. I'm going to very briefly talk about the ugly laws, the quote, fear of feeble-mindedness, and the US eugenics movement. And I want to note that for this section, the language that I use here is language of the time. It is not my own language nor language that I endorse. So as the US underwent rapid industrialization, cities grew dramatically. Railroads allowed goods and people to traverse the nation. This was the period in American history of the most dramatic social mobility in the US, as people really did go from rags to riches, riches to rags. But this is also the time when factories and packing plants cut off fingers or toes, blinded their workers, gave them fun respiratory diseases due to the horrible working conditions and lack of labor protections. But this is really the era of pull yourself up by your bootstraps. It is when American identity was being defined not by aristocracy, but by one's ability to work and to contribute economically to society. And this was great, unless you were one of those workers who was injured on the job, or were injured in the Civil War, or you were an unmarried woman trying to support yourself, or you were born with an impairment that prevented you from participating in the economy in traditional ways. And one of the growing moral problems of the day during this time period was people begging for money, interrupting the free flow of commerce, disgusting tourists, keeping prosperous citizens from enjoying urban amenities. This phenomenon became such a recognized problem that city officials across the nation started discussing how to clean these, quote, undesirables, end quote, out from their city streets. Enter a series of city ordinances that later became known as the ugly laws. Now, this is a double entendre nomenclature. The scholars who first studied these laws dubbed them ugly because they revealed such an ugly chapter of our history, but also because these laws literally made it illegal to be ugly. Once implemented in a few cities, many urban areas adopted pretty much template language, making it illegal for people with physical impairments to expose themselves in public to beg for money. And here's the stock text of these laws, where there's some variation of these city ordinances. Quote, any person who is diseased, maimed, mutilated, or in any way deformed so as to be an unsightly or disgusting object, or an improper person to be allowed in or on the streets, highways, thoroughfares, or public places in this city, shall not therein or thereon expose himself to public view, end quote. Now, these were city ordinances, not state laws, and there doesn't seem to be evidence of whole waves of people arrested under these laws. They were used mostly to threaten people with arrest and get them to move on. But these laws highlight the way in which disability was and continues to be deeply intertwined with poverty. That is, that the social status of being disabled was and is both a cause and a consequence of poverty. So the ugly laws focused on people with physical impairments, but there were also concerns about folks with non-apparent impairments. During the late 19th and 20th century, industrialization, urbanization, and increased migration all combined to create significant social changes in the US. And with big social change comes new social anxieties. One of these anxieties centered on what was referred to as, quote, feeble-mindedness, or what we would today call cognitive, intellectual, or developmental disability. The fear was that feeble-mindedness was contagious as well as hereditary, and there were growing concerns that this, quote, defect, if unchecked, would spread through the population like an epidemic. A physician and social reformer stated in 1912, quote, feeble-mindedness is an absolute dead weight on the race. It's an evil that is unmitigated. Their very existence is itself an impediment, end quote. Now, if your ears perked up at the mentions of concerns about the state of the race in that phrase, you're not alone. It is precisely this time and building off of these types of arguments that eugenics started to bloom in the American imagination. Now, I'll be very clear, eugenics is a pseudoscientific endeavor. It is not based on science to improve population quality. But it begins to both fuel and build off fears about difference, arguing that, quote, defective people, they cause poverty, they cause crime, they lead to the moral decline of society in general. And you can hear from this language that people at the time were mushing together all sorts of traits into this category, not just physical or mental impairments, but being poor, engaging in criminality, including prostitution, and really anyone who just didn't conform to the morality of the time, which that these ideas were largely shaped by class, race, and education levels of those who were in power at the time. And all of these qualities got lumped into this broad category of disability. At its heart, eugenics is a tool of social stratification. And by framing, for example, intellectual disability as a potential epidemic, the eugenics movement justified medical, social, and legal restrictions and ways of regulating people's lives, including institutionalizing and forcibly sterilizing men and women deemed to be, quote, feeble-minded. According to eugenicists, these individuals lacked rationality, moral judgment, the ability to achieve self-sufficiency. These were anti-citizens, if you will. They were at best dead loads or social evils, actual language used at that time. This epidemic of the feeble-minded was often pointed to as a greater threat to the nation than war. And so in an effort to prevent these individuals from creating more burdens on society, states began quietly sterilizing people housed in prisons, asylums, institutions, and orphanages. These practices were indeed challenged, going all the way to the Supreme Court, where in 1927, the court ruled that forced sterilization was an acceptable practice in the Buck v. Bell decision. Between 1907 and 1963, over 64,000 individuals living in institutions were forcibly sterilized. However, before we wipe our hands of this long history a long time ago, I'll remind you that many countries today still forbid people with certain types of disabilities from marrying or having children. But to move our pop-up book of disability history into a more cheery territory, I'll next focus on some examples of the ways that people with disabilities have pushed back against these biases, sampling some advocacy movements and the laws that resulted from them. So here too is a rich history of advocacy and struggle, not just to combat disability bias from the past, but also to challenge disability bias in the present. And I want to briefly mention 4 important social movements that shaped our current patchwork of legislation regarding disability. The first is a broadly rehabilitation movement. About the 1920s to 1940s, we have 2 generations of veterans returning from world wars who come home to advocate for recognition, benefits, push back against the stigma attached to disability. This was also a period of heightened concern over polio outbreaks. So this is an area that was really characterized by the development of the field of physical therapy, the beginnings of rehabilitation services as we think of them today. 1950s to 1980s, we see the deinstitutionalization movement. And this is where parents really began starting to refuse to place their disabled children in institutions and raise them at home. It's also during this time period that the quote, people first language starts to appear in advocacy circles. This movement, largely driven by parents and caregivers, had to assert that their children were indeed people and that they were not willing to allow them to be warehoused like animals. Hence, the popularity of this phrase or this language convention of people first language. My guess is that many of you in the medical profession were also trained to say people with disabilities. This is a legacy of this movement to keep us from forgetting that individuals, especially those who may not speak verbally, are indeed people. Then about the 1960s to 1990s, we see the independent living movement. Here we have parents, caregivers, but also many people with disabilities themselves who want to live in their own homes or group homes. They demand access to public education. And this leads into and is part of the larger disability civil rights movement, which will clock at about the 1960s to present. In the disability civil rights movement, it's primarily disabled people who advocate for full citizenship rights free from discrimination. It's during this period that cross-disability coalition really emerged. So like in the Black Civil Rights Movement or the Women's Rights Movement, people with impairment started to recognize that the shared experience of discrimination was far more powerful than the shared experience of a particular type of disability. And it's in the 1990s and on that more and more people living with impairments began to see disability as a site of identity, a site of culture. Hence the language convention of folks who identify themselves as a disabled person rather than a person with disability. Now, to be clear, neither of these language conventions are wrong or right. It simply depends on how a person wishes to be referred to. Now, of course, I would be remiss if I did not highlight the nationwide and sustained protests that finally pushed the Americans with Disabilities Act to be signed into law in 1990. On this slide is a black and white photograph of what has become known as the quote Capitol crawl, in which disabled activists descended on government buildings across the nation, and individuals with mobility impairments drug themselves up the steps of those buildings to symbolize the many ways they were being shut out of decision making about their own lives. This photo, taken by Tom Olin, O-L-I-N, focuses on Shayla Jackson scooting backwards up the steps of the Capitol building in DC. And what is the result of all this fomenting for rights? Well, we now have a patchwork of laws passed over the last 100 years covering varying aspects of the lives of people with disabilities. This slide shows a list, an incomplete list, by the way, of the major laws that impact disabled Americans today. And you're not meant to be able to read all of these laws. This is just to give you kind of a snapshot of the list. And in fact, here is another snapshot. This slide is simply these laws that are organized by substantive category rather than legal code. And the point of showing you this patchwork or this quilt of laws is simply to reinforce my earlier point. There are many different models of disability out there, in part because there are several different definitions of disability embedded in our legal system. Not to mention different definitions embedded in our healthcare system, our educational system, et cetera, et cetera. And yes, there are direct contradictions and tensions between some of these definitions and these laws. Recall the Social Security definition I showed earlier, in which the definition was entirely based on ability to work. But not to worry, the definition that you need to know is the one that's under the ADA. So it's important to remember that in the context of the ADA, disability is a legal category, not a medical one. The ADA defines a person with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activity. This includes people who have a record of such an impairment, even if they don't currently have a disability. It also includes individuals who do not have a disability, but are regarded as having a disability. I know it can be kind of confusing. The ADA also makes it unlawful to discriminate against a person based on that person's association with a person with a disability. So we're giving you this history so that you understand why the ADA specifically addresses impairments, why it addresses stigma, the social stigma that has been historically associated with disability. It's because the ADA is shaped by a diversity's perspective of disability. This is a law that's intended to prohibit discrimination against folks with disabilities, aiming to help reduce disparities in social outcomes, including disparities in health outcomes. And that brings us right up to the present. Is ableism present today? Well, unfortunately, we know that it is because we continue to see differences in social outcomes that can't be explained away by other metrics. Whenever we review the history followed by successful advocacy of a marginalized group, it becomes all too easy to think, well, glad we solved that one. We've got laws, right? Or maybe even to entertain the thought, well, at least it's not as bad as it used to be. But we all know better. Ableism, like racism or sexism, is intersectional. Just as we continue to live with the legacies of racism, of anti-Semitism, homophobia, and transphobia, just to name a few, that continue to generate disparities in social outcomes for those groups, ableism and disability bias continue to persist today. Research has shown us that some of the severe and long-lasting detrimental effects of institutionalized discrimination on affected populations include increased rates of suicide, decreased access to education and employment, decreased access to healthcare, decreased political representation, suppressed attainment of wealth. And so I want to share just a few of these with you to glance at where we're at today. Let's start with employment. So I've put up here a bar graph that compares the employment to population ratio for people 16 years and older, broken out by race and ethnicity. This information is 2021 data taken from the current population survey, and employment ratio measures the proportion of people from a group who are working out of people in that same group. So this bar graph compares the proportion of employed disabled people, the dark blue bars, to the proportion of employed non-disabled people, the orange bars. The last bars on the far right show that in 2021, roughly 64% of non-disabled people aged 16 or older were employed, compared to only 19% of disabled people. Other bars compare these ratios between disabled and non-disabled people by race and ethnicity. For example, only 15% of Black disabled people are employed compared to 62% of Black non-disabled people. This is a similar kind of difference for both Asians and slightly higher for Latinos and whites. The difference between employed people with disabilities and employed people without disabilities across these racial and ethnic groups range from a 43 to 47 percentage point difference. But you might think, what about education? That's an important part of the equation. Education is the big equalizer, right? Well, wah, wah. Sorry, folks, but here is another bar graph looking at how the employment to population ratios look across different levels of educational attainment. As this graph indicates, the presence of disability significantly impacts employability regardless of educational attainment, with again, percentage differences proportionally remaining around 42 to 46% less for disabled folks. And if we were to look at just one of these, for folks with a bachelor's degree or higher, which I'm guessing is most of everyone here today, we still see a dramatic difference. That non-disabled people with a bachelor's degree or higher, just over 73% of them are employed, compared to only 20% of disabled people like myself with the same level of education. And I'm guessing you all know where I'm headed with this, right? Next, I want to talk about disparities in healthcare. So I just pulled a couple of metrics to demonstrate some disparities in our healthcare system. I have included the citations on the bottom of this slide, and these data are drawn from the 2010 Agency for Healthcare Research and Quality Disparities report. So this table shows that among those who reported needing to see a doctor in the last year, but who did not, the proportion of disabled people are double that of non-disabled folks. Looking at just women, among women who got a mammogram in the last 2 years, 65% of disabled women got a mammogram compared to 74% of non-disabled women. For those getting a simple Pap test, 69% of disabled women received one compared to 83% of non-disabled women. And we've been doing this research for quite a few decades now. We have seen throughout a variety of studies that key barriers to accessing healthcare for people with disabilities include inaccessible healthcare facilities, that is, sometimes not even being able to get in the door, inaccessible healthcare equipment, like not having exam tables that are accessible or the ability to do transfers from a chair to a table, inadequate anticipation of accommodation needs. So not being set up to have folks who have service animals come into the office, not having effective means of communication materials prepared or ASL interpreters arranged, negative perceptions of and assumptions about people with disabilities more generally. Now, all of us at the Oregon Healthcare Authority and the Northwest ADA Center care about all of these. But for today, we're focused on this last one. We're focused on disability bias. So as one example, I want to share with you the results of a recent study published by Dr. Lisa Iazzoni, Iezzoni, and her colleagues in the journal Health Affairs. And this was published in 2021. Lisa and her colleagues draw on a survey of 714 practicing physicians across the United States. And the researchers found that 82.4% of those physicians reported that people with disabilities have a worse quality of life than non-disabled people. Shockingly, only 41% of physicians reported feeling very confident about their ability to provide the same quality of care to patients with disabilities as they provide to those without disability. And only 57% strongly agreed that they welcomed patients with disability into their practices. So more than 30 years after the Americans with Disabilities Act, 1990, was passed, these findings about physicians' perceptions of this population raise really critical questions about ensuring equitable care to disabled patients and people. Potentially biased views among physicians very likely contribute to the persistent healthcare disparities affecting disabled Americans today. Now, I know you're probably on the edge of your seats waiting for the solution, but we can only accomplish so much in one webinar. But don't worry, so this is just the first. There are more coming. As a recap, I just want to remind us of what our learning goals for today's webinar was. Hopefully, you now have an understanding of disability from a diversity perspective. You can reflect on how US history has impacted our current perceptions of disability. Hopefully you have a better understanding of how multiple, sometimes conflicting definitions of disability have become embedded in federal legislation. And I'm hoping that you understand the historical and political context in which different language conventions around disability emerged. And mainly, we hope that everyone recognizes the impacts of persistent disability bias and ableism on the ways in which accessibility barriers perpetuate systemic marginalization. And so I'm hoping that everyone here is asking the question, but what do we do about it? Well, what we hope is that you will create more accessible and equitable healthcare practices by building on this foundational knowledge, and that you'll continue to learn more about disability bias in healthcare. And while there are lots of tools out there, this webinar series is designed specifically to help you create more accessible and equitable healthcare practices. We hope that you will attend our entire webinar series and use the information such as fact sheets and short videos that will be available to you at our website. And that is at the northwestadacenter.org/OHA-healthcare. And to let you know what's coming up, in our webinar series, our next webinar will be on physical access and telehealth to make your practice more accessible. The third webinar will be on effective communication and reasonable modification. That'll be in March. And then in April, the date still be determined, I will see you again with my colleague, a physical therapist, in which we will have a short panel and talk about our best practices and tips for engaging in disability allyship in healthcare settings. So with that, I am looking forward to moving to some questions from the audience, and I'm going to turn it back over to Dr. Warden.
Hi, Heather. Thank you for that. So we have a great question to start with. Can you speak more to the idea that some disabilities, such as chronic pain, are not valuable to anyone and we should try to cure them? I'm really excited to hear your thoughts. This is something we've talked about a lot.
Thank you very much. So before I address that, I did want to note that we are going to put an evaluation link in our chat for folks to complete the evaluation. And I just got pinged to remind everyone that if you have signed up for continuing education credits, you will need to complete that evaluation. So you'll see that link in the chat go out in just a moment. All right. Oh, this is a great question to start us off. Can I talk about how there is no value in chronic pain and that we should absolutely be looking for a cure to that? Well, this is a question that affects me very personally. I have a degenerative disease. I do live with chronic pain. And the first thing I would say is that, yes, absolutely. Will someone snap their fingers and take this pain away? Yes. The second thing I would say is, honestly, I would push back. I would push back on the assertion that there is no value in this experience. There is a tremendous amount of wisdom, literature, activism, as well as arts and culture that has come from individuals who are exploring the experience of having pain. In disability studies, we often talk about complex embodiment. And if you're interested in this, you can look for Tobin Sieber's, S-I-B-E-R-S, Tobin Sieber's work on embodiment and the way that those of us who live with any condition, how it shapes the way that we see the world and how we interact with others. And oftentimes pain, whether chronic or temporary, is the type of condition that has the potential for building deep empathy, for understanding ways to engage in activities and accomplish goals that are, frankly, maybe innovative or adaptive and not particularly the most typical or most efficient ways that have been identified for us. And so I in no way am I trying to diminish what it feels like to live with chronic pain. But I also would encourage anyone who lives with chronic pain to dig into the literature on things like access intimacy and the kind of interdependence and mutual aid and cultural significance of people who have come together to share their experiences of chronic pain and to support each other through those experiences of chronic pain. And while yes, again, let me end with absolutely give me that pill, I will say that part of the human condition is that we will experience pain at some point. And for some of us, that's more frequently than others. I see a couple of questions coming in.
Yeah, thanks, Heather. Let's see, we've got quite a few coming in. I like this first one though. What is your vision for the future of disability self-advocacy in Oregon and Washington? And I know that's broad, maybe thinking about that in the context, the healthcare setting.
Yes, thank you. What is my vision for the future of disability advocacy in Washington and Oregon? We'll say the Pacific Northwest. How about that? You know, interestingly, I think right now what is where there's a lot of advocacy and activism happening is in disability justice. And if you're not familiar with that movement, the disability justice movement, I encourage you to check out Sins Invalid, INVALID. Yes, it sounds like Sins Invalid, but it's Sins Invalid, who has a great primer on disability justice. And I would say that really it's about a deeper and broader cross-coalition building, not just across disability or impairment types, but across shared experiences of marginalization and oppression. So a great example would be the Black Lives Matter movement. That was a movement in which many of its leaders were very explicit and intentional about talking about the importance of pushing back against oppression and violence against not just Black people and not just people of color, but Black disabled people, people of color who are queer, trans people, etc., in order to understand the ways that these systematic forms of oppression interlock and support each other. And so, especially in the Pacific Northwest, I really do see that there's going to be more sustained community building. And while the law, as a sociolegal scholar, is great, we need those rights. We need to have non-discrimination codified in our system. There's a limit to what the law can do. And it's more through education, through webinars like these, to being willing to see the similarities across our different groups more than our differences so that we can begin to really advocate for social justice for all marginalized groups. And at least in the groups that I'm involved with, that is the direction of disability advocacy and activism right now.
Thank you, Heather. So someone's raised their hand. Alex, I'm going to allow you to come off mute if you'd like to ask Heather your question. Oh, well, sorry, this is Katie. Doesn't look like the technology is working right now. So Heather, I'm going to go to the next question. And Alex, please, if you can come off mute, feel free to speak up or reach out to us. This is a great question for you, Heather. Was it ableism during COVID when healthcare providers were deciding who would and would not get the use of a ventilator?
Yes, this is definitely a question that many disability scholars, we talked a lot about. It's a combination, I would say. Whenever we talk about rationing care, and certainly the COVID pandemic was one of those situations, then we are starting to really question deservedness. Who is most deserving? And when we start to ask questions like who is most deserving to continue to live, there are all sorts of philosophical and ideological kind of strains that people pull on to make those really hard decisions. Now, in a perfect world, we would have plenty of resources for everyone. But when resources are scarce is when we begin to see these biases really start to bubble up to the surface. And so conversations about which groups do we just monolithically decide shouldn't have the same access to healthcare as others, or who is more deserving, or who has more of a right to live, then we are absolutely stuck in the weeds of all sorts of isms. And ableism is definitely one of them. When we start to make assumptions and judgments about the quality of life and or the quality of contribution or the way that somebody can contribute to society. So that is a very long, jargony answer to say, frankly, yes. Yes, it is. It doesn't mean that decisions in some circumstances don't have to get made and that those are horrible decisions, but it's important that we understand and that we're honest about what is the logic that underpins the decisions we make when we start to ration care.
Thank you, Heather. That was a great answer. So this is a question about the percentage of providers who feel they're unable to treat a person who has a disability as well as they treat non-disabled people. How much of that kind of feeling that they can't provide equitable treatment is due to their own perceptions of disabled people, and how much of it is due to the resources they have available to them? I.e., maybe they don't have accessible medical equipment and their practice might not be set up in an accessible way.
That is a great question. And off the top of my head, again, I encourage you to, we'll make all of the slides available to read the article that Dr. Iazzoni and her colleagues put out. My recollection is that they didn't parse that out. They didn't parse out what was the key factors or mechanisms by which physicians reported, I just don't feel as confident to be able to provide the same level of care to my disabled patients as my non-disabled patients. Fascinating potential research question out there, but that information coupled with the well-documented barriers of the lack of accessible facilities and exam equipment, et cetera, can tell us that certainly, again, we come back to that argument of we all have limited resources, but, you know, as a friend of mine likes to say, budgets are moral documents. We do make decisions about where those resources get allocated. And so certainly that's going to be part of it, because we know a lot of physicians, a lot of healthcare practitioners in a variety of spaces are saying, I just don't have X, Y, or Z to provide accessible treatment or accessible diagnostic tools. On the other hand, we know that disability bias persists across healthcare fields. And in our fourth webinar, when I'm going to have some, Dr. Feldner and I have done some research together, and she's done some research looking at both implicit and explicit bias among healthcare providers. And so those two together, honestly, is what I would say is, does it matter which of those is a bigger driver in the lack of equitable care being provided? I think that we have a lot of work to do across both those categories, if you will. And I would say that if you're strapped with resources, that doesn't prevent you from, again, being really thoughtful about other ways that you can provide accommodations.
Thank you, Heather. I think we have time for one more question. And I think it's a nice question to end with. Are there any known resources that exist for healthcare facilities to use in order to make doctors' offices more ADA friendly?
Wow. Yes, what we're doing right now. Yes, thank you, whoever asked that question. Again, this collaboration between the wonderful folks at the Oregon Health Authority and the Northwest ADA Center, this is our endeavor. We are trying to pull together and compile in one place a set of resources that will help you in whatever your capacity, whether you are a front desk receptionist, whether you're a social worker, whether you're a practicing physician or a surgeon, et cetera, et cetera. We're trying to pull together resources to make it really clear what the expectations are under the law, and to encourage you and provide support to go further than compliance, but to be very thoughtful about providing equitable care and really thoughtful and good health care to disabled peoples and patients. So again, I'm so glad you asked that question. This is exactly what we're trying to do, is trying to elevate this message and this information and get it out there. So stay tuned with us for the webinar series, and I encourage you to check out the information that we have provided.
Well, thank you all so much, and thank you, Heather. Remember, if you have a moment, please fill out our survey to give us feedback on the webinar. This is also kind of the first step in making sure you can receive continuing education credit. So, Heather, if you want to say, kind of end the webinar for us, that'd be great.
Great. I just want to thank all of you who gave us your lunch hour. We really, really appreciate it. Again, this was just the foundations. We do have tips and best practices coming. Hang with us. But kudos to all of you who've taken this huge first step, really, in challenging and learning about disability bias. And we look forward to seeing you next time.